Good evening, everyone. Welcome to the Tuesday academic session, where every Tuesday we bring about a new topic to discuss. And today we are going to discuss about DAH in Leptospira ARDS, a battle for breath. And I'm privileged to have two expert panelists for this. Dr. Somnath Gupta sir, who is a senior consultant physician and a diabetologist from Yashoda Hospitals, Hitec City. Thank you, sir. Thank you for joining us. And we have Dr. Pratib Prasad, who is a consultant interventional pulmonologist from Yashoda Hospitals, Hitec City, joining with us. Thank you for joining, Pratib, sir. So, going forward, we are going to discuss about a case which we have encountered in our setup, which is not very common. So, this is about a 47-year-old female who is a botany lecturer by occupation from a nearby place to Hyderabad. She doesn't have any significant past medical history other than recently where she was diagnosed as a psoriasis and she was on some topical emollients. This lady presents to us with a history of high-grade fever with chills, headache, and body pains, and which was almost close to a week or so. And the myalgias were so severe, and she started to have severe, significant weakness. For which she was initially evaluated at a local hospital, and there she was treated in lines of probable sepsis with antibiotics with an unknown source. And she started to develop pain abdomen with decreased urine output with since one day. With these complaints, she was brought to our emergency on 27th of last month in view of her worsening condition. So on arrival to the emergency, she was in respiratory distress with severe high anion gap metabolic acidosis with a lactates of 6.2 and a saturation of 97% on room air. And the initial labs which were done outside showed a hemoglobin of around 10.3, total leukocyte count of around 14,000 and a platelet of 30,000. She also had renal involvement in the form of an acute kidney injury, urea of around 115 and a creatinine of 4.8, and a deranged LFT with hyperbilirubemia, more predominantly of direct bilirubin with a transaminitis, which is mild. The initial ABG which was done in the ER showed a pH of 7.2 with a bicarb of around 14.4 and a lactate of around 6.1. So we continued, with fluid resuscitation for her, and an isotonic bicarb infusion was started to correct her acidosis, and a nephrology input was taken, and an ultrasound abdomen was done from the ER, which showed a relatively small right kidney with a right significant PUJ calculus and a left PUJ calculus causing mild hydronephrosis with some grade 1 renal parenchymal changes. At this point of time, the X-ray which was done was also normal. And the differential diagnosis, what came to our mind at that point of time was, because she presented with a significant thrombocytopenia with a multi-organ involvement in the form of a liver and a renal involvement. The first differential diagnosis at this point of time in this season, generally we have to suspect about tropical fever. That is what we have suspected. And she also comes with a, outside diagnosis where the dengue IgM was weakly positive. So we also have asked for scrub and lepto considering this setting. And the other differential diagnosis with ultrasound suggestive of PUJ calculus with hydroureteronephrosis, a urosepsis with MOTS was also in our consideration. So we started around ceftriaxone and doxycycline after sending blood and urine cultures. As I said, dengue, lepto, scrub serology was repeated again. And the CU was consistent with UTI with a pus cells of around 21 and a bacteria of around 80 with a leukocyte estrase positive. But it also showed a 2+ proteinuria along with a significant RBCs in the urine. A CT KV was also done to confirm the same, which showed a right small kidney with PUJ calculus and a left proximal ureteric calculus with a hydroureteronephrosis. Because the CU was also consistent with the with the urosepsis, we have empirical escalated the antibiotics to carbapenems. And this was the CT-KUB of that patient, where the left kidney is quite enlarged, the right is small with a significant large PUJ calicus. And this was the initial, CT of the lung, which we could get from the cuts what we have taken during the CT-KUB. Here also the dengue IgM came weakly positive and the NS1 was negative. Of course, it is in the almost close to a week, and the scrub came negative. But the patient's condition started to deteriorate, where she started to drop her pressures and she was requiring minimal vasopressor support. And as a compensatory mechanism, she started to have hyperventilation, which was supported with HFNC support at this point of time. So as a part of workup, we have done ECG, which showed some sinus tachycardia with non-specific ST depression V3, V6, and a 2D echocardiography was also normal. Because it was suspected to be UTI urosepsis, we had taken a urology review in view of the hydroureter nephrosis, where they suggested for bilateral DJ stenting for the source control. However, the challenge here was the platelets were 30,000 initially, which dropped to 19,000 on a repeat sample. And to prepare her for the surgery, we have transfused 1 unit of SDP. Pre-surgery, in view of the significant metabolic decompensation, we have done 1 session of renal replacement therapy with hemodiafiltration for metabolic optimization. As she was tachypneic on HFNC, she was electively intubated in the OT for the procedure. But when you look at her post-intubation ABG, it was showing significant hypoxemia with hypercapnia. Although the acidosis was partially corrected and the lactates were trending down, what was scary at this point of time was the amount of hypoxia what we were seeing after the intubation. And the endotracheal tube had hemorrhagic bloody secretions, and she also had hematuria post-operatively. So in view of these bleeding manifestations, what we initially thought was probably she was having some amount of bleeding secondary to thrombocytopenia. As her INR was within the normal limits, we have again transfused her with 1 unit of single donor platelets. So this gave us a suspicion that probably whether this patient was suffering from a diffuse alveolar hemorrhage at this point of time. And she was ventilated on a pressure regulated volume control mode with 100% FiO2 and a P which was gradually increased to achieve an optimal ventilation up to 16. So we used all the conventional strategies of an ARDS ventilation, like low tidal volume, high PEEP, targeting our driving pressures, despite which the PF ratios were less than 100, which is around 96. So in view of this, considering her clinical condition, we had to prone her. And for our surprise, the Leptospira IgM test came out to be negative. However, the thrombocytopenia, along with an acute kidney injury and a hepatitis picture with an acute liver lung involvement in the form of an ARDS, still we had the tropical fever on the card. Although the dengue was, faintly positive, we were not convinced with the diagnosis of the dengue with ARDS, because if you look at the clinical picture, although there was thrombocytopenia, it was more of a bilirubin derangement rather than a transamendinitis, which is not very typical of a dengue. So our consideration now tilted towards whether are we missing any autoimmune vasculitis because of the renopulmonary involvement, because she present with an acute kidney injury needing a renal replacement therapy along with a rapidly worsening hypoxia with a hemorrhagic ET secretions, making us tilt towards diffuse alveolar hemorrhage. So an autoimmune workup in the form of an ANA profile and an ANCA vasculitis was also suspected, and a C-ANCA and P-ANCA were sent. And if you compare the X-ray which was done prior to the procedure and post-sheath insertion, this was the X-ray. And within probably next 6 hours, she started to have diffuse bilateral infiltrates, which was very rapidly progressing with a severe hypoxemia. And this was the initial, lab reports what we have seen earlier. The hemoglobin was on the lower side. And if you look at the trend of the hemoglobin, which was dropping from 10.3, 9.8, 9, and subsequently 8.1. The platelets initially were around 30,000, and after coming here, we have repeated, which is around 50,000, and we have transfused 2 units of SDT, because of which the platelets were holding around 1 lakh to 90,000. However, at this point of time, there was no coagulopathy, and the renal parameters gradually improved because of the dialysis sessions what we have done. And if you also look at the derangement in the liver parameters, it was predominantly of the direct bilirubin rather than indirect bilirubin. And there is mild transaminitis, which is again not very typical of a dengue infection what we see. For our surprise, again, the ANCA and the ANA came negative. Even the anti-GBM came negative, and the C3, C4 levels were within normal limits, of course, on the lower side. So we have asked for a CPK suspecting Leptospira, and CPK was borderline elevated, not very significant. And in view of our strong clinical suspicion, we have asked for a lepto-PCR because the lepto-IgM was negative, and in an empirical therapy, we have added benzyl penicillin for the leptospirosis. And we continued with our prone ventilation and supine ventilation. However, we had turbulences whenever we tried to supine her, because she had episodes of desaturation and bradycardia, because of which we were unable to supine her for an extended period of time, where we had to do a prolonged proning almost up to 20 to 22 hours. And if you look at the improvement in the PF ratios, the PF ratio hardly improved from 96 to 126 despite the proning. However, as a desperate attempt, we had no other choice, but we continued with the proning. And during the second session of proning, she had a bradycardia requiring 1 dose of adrenaline without a cardiac arrest, actually. So what we understood was, whatever rescue therapies which we are doing were not able to help her. And by this time, we had our blood and urine cultures along with the ureteroscopic cultures which were sent from the OT, which turned out to be negative, which did not help us, in moving forward. So at this point of time, there was a lot of dilemma and debate, because the patient was having significant thrombocytopenia, and along with the bleeding manifestations in the form of an hemorrhagic ET secretions and hematuria. So the only rescue therapy available to us at that point of time was a veno-venous ECMO. But considering her setting, it is very high risk because she could bleed and die. So we have carefully, evaluated the pros and the cons. And after deliberation and discussion with the family, what we felt was, if we have not proceeded with ECMO, there is no other chance. And if we proceed with ECMO, there is at least a possible chance that she might recover if she doesn't bleed. So after counseling the family extensively, we proceeded with the veno-venous ECMO at a high risk without any anticoagulation support at that point of time. So we did a femorojugular veno-venous ECMO, where a 25 French venous access was secured in the right femoral vein, and a 19 French return cannula was secured on the right jugular vein. And we have initiated by day 3, because she presented on 27th, and by day 3 she was initiated on ECMO with a flow of around 3.5 liters per minute and a fresh gas flow of almost around 4 liters per minute. So this was post ECMO initiation, and if you look at the X-ray, you can see the ECMO cannula here, where the sheath was removed and was exchanged to a ECMO cannula on the right side. And you can also see the right femoral cannula, which is almost at the junction of the subhepatic junction. So till this point of time, although she was bleeding, we were not able to consider any form of intervention in the form of a CT chest or a bronchoscopy in view of her significant hypoxia. Once we have established her on ECMO, we did a bronchoscopy, where we could see there were thick clots and a bronchoalveolar lavage was done. And we have sent the BAL for the hemocyte and latent macrophages, and they came negative. And the LRTI panel was also negative, ruling out any active infection at this point of time. So what was the event which is, making her progress so rapidly over the 48 hours, where, she went on from without oxygen support to a HFNC, then intubation, then prone, then veno-venous ECMO. So again, we had a lot of debate and a discussion, where a probable, ANCA negative vasculitis or an ANA negative vasculitis is a possibility. And with a great strong intrusion, we have repeated a lepto-IgM, which came out to be positive. She required only 2 units of PRBC transfusion post initiation of ECMO. We did ECMO cannulation without any major bleeding manifestations or any platelet transfusions. So after the lepto-IgM came positive, we were very hopeful that this is all the capillarities which is causing the bleeding. And after careful consideration, we started her on a low dose anticoagulation with heparin at 250 to 500 units per hour, targeting the ACT on a lower side, that is 140 to 160. And this is the CT which we have done post ECMO initiation. You can see the ECMO cannulas. And if you look at the CT chest here, hardly there is any lung which could be ventilated, and that is clearly explaining us the difficulty what we had in ventilating with a conventional ARDS ventilation. Once we have initiated her on a veno-venous ECMO, we could come down to the rest ventilatory settings where the FiO2 was gradually tapered and the PEEP was reduced to 6. And over time, the complaints they got better and the X-ray chest was gradually resolving. And the platelets were still hovering around 60 to 80,000, where there is no coagulopathy. Of course, we are trying to target our ACT to 140 to 160 and the APTT around between 60 to 90. There were challenges in optimizing her anticoagulation because she has ongoing bleeding because of the intervention in the genitourinary tract, as well as the hemorrhagic ET secretions which she was having. And we try to keep these patients awake as much as possible without the paralysis. And post that, she had an altered sensorium where we have considered differential diagnosis of query aseptic meningitis or query delirium, and we tried to manage it with dexmedetomidine and quetiapine. Gradually, her shock got better, the acidosis started improving, and the PO2s were optimally maintained, and the lactate started normalizing. By day 3, we were able to start tapering on the ECMO oxygen support from 100 to 80%, and we could come down the flow to also 2.5 liters per minute. And by second, almost close to 5th day, she was off RRT as she started to have good urine output. And if you look at the trend of her hemoglobin and the platelets, they started improving, and hardly we required any further transfusions to maintain her hemoglobin level. The only challenge at this point of time was the leukocytosis which we have encountered, where the counts were almost around 30,000, 35,000, 40,000, where the peripheral smear also was showing toxic granules, and because of which we could not consider high dose steroids in her. Of course, we have considered stress dose of steroids for this patient. As I said, she had ET tube bleeding, and there was a tube block needing a change with an 80,000 platelets. We could exchange the tube without any transfusions. The cannula sites did not reveal any bleed, and the ACT was still maintained around 158. We did a repeat BAL in view of the clots what we were seeing. We could see some clots, and we have repeated again the BAL cultures and the hemocyanin-laden macrophages. The bacterial cultures did not reveal any growth, and the BAL cultures had a lactose fermenter E. coli, and the antibiotics were escalated accordingly. By day 11 of illness or by day 6 of ECMO, the platelets started crossing 1.2 lakhs, where we had a decrease in the bleeding what we were seeing earlier. And once we started to see that improvement, we started weaning of ECMO, where the fresh gas flow was dropped to 1 liter per minute, and the ECMO oxygenation was brought down to 21%. And by 6th of October, we could decannulate her in the ICU, and the next day we could extubate her onto the HFNC by 7th of October. There were some challenges in managing her sugars, and she had hypertensive episodes, which were conservatively managed. And by the next day, we could bring her to nasal prong support. Post ECMO decannulation, because we had, initially we could not anticoagulate her, we did a DVT screening, which was negative. And within the next 2 days, she was shifted to room, and within the next 5 days, she was discharged home. without any oxygen support at the point of discharge and without any residual organ failure. The total stay was almost as close to 18 days, where she required a venous ECMO support for 7 days, which was very short considering the CT image what you could see. So I'll briefly touch upon leptospirosis. Leptospirosis is a zoonotic disease which is typically endemic to tropical countries, which is not very commonly seen in the West. And its mode of transmission is from animals to humans, where the infectious agent is a bacterium which belongs to the genus Leptospira. Generally, it is transmitted by the humans coming in contact with a contaminated water, which is contaminated by the urine or the feces of the common reservoirs which we come across. And this doesn't directly penetrate the skin. There should be generally a breach in the skin, or it should directly come in contact with the mucosal surfaces like sclera or conjunctiva. And the typical common reservoirs being the rodents, cattle, horses, sheep, goats, pigs, and dogs. The incubation period typically, usually is around 1 week to 2 weeks, although it can be prolonged up to 4 weeks. The most common presentation is generally mild, typical flu-like symptoms, and they generally recover. It has different phases where initial the acute phase is seen in most of the patients, where you can see it for a week or so, where you can see a mild hepatic derangement along with a fever and jaundice. And the second phase is the immune phase, which is again characteristic for 1 week, and it is characterized by the production of antibodies, where we start to see the antibodies. Some patients present into the fulminant phase, where they have a severe hepatic, renal, and pulmonary involvement, which is characterized by capillary vasculitis, which is a predominant pathophysiological mechanism for causing the organ injury actually. And as it was described by Weils, it is called a Weils disease, which is characterized by jaundice, acute renal failure, and a bleeding manifestations. If you look at the pulmonary involvement, it is not very common. It is mild in most of the cases. However, rarely it can present with hemoptysis, along with cough, shortness of breath, and a high-grade fever, which can progress to diffuse alveolar hemorrhage and can turn into ARDS also. So I would like to share some articles where we have reviewed the literature, where if you look at the outcome of severe leptospirosis presenting with ARDS in a respiratory ICU, this paper came from Maharashtra. So if you look at by day 3, if the PF ratio is less than 100, the mortality is as close to 90%. And the requirement of invasive mechanical ventilation carried a mortality risk of around 70.4% with an overall mortality of around 40%. This is the data from the India where we are presenting. And the second study is, another study from India itself, where again they have showed that, severe pulmonary hemorrhage syndrome in leptospirosis is an uncommon but an emerging presentation, where they could, manage this patient with ventilatory support and a steroid dose. And I'm surprised to see that this case report is from United States of America, where they had a severe diffuse alveolar hemorrhage and the patient could not survive despite the best management in one of the best centers in the world. So to summarize, it is not very common, but if it happens so rapidly and so severely that the time may be very short. And the clinical presentation is very important for us to pick up the clinical clues, which helps us to tip towards the diagnosis and do the right or timely intervention, which can turn the patient. So with this case presentation, I would like to take comments from both Dr. Somnath Gupta sir and Dr. Pratib sir. Sir, any comments on this case, sir?
I remember this case very vividly, sir. So I remember having multiple discussions with the ICU team. I think the strong clinical suspicion of the ICU team, made you send the Leptospira IgM a second time, Lepto PCR. And despite having the Lepto IgM negative, we continued on benzyl penicillin and doxy. I think the clinical suspicion overruled any laboratory diagnosis in this case in the initial period, and that is what ultimately helped the patient to come out from this disease.
Yeah, as Dr. Pratib sir said, it is definitely there are a lot of diagnostic lacunas in the case. When it came up, it was with they thought it was a dengue positive as well as IgM positive, and platelets were low. We initially thought it was dengue, but the clinical picture when they came up, it was not only thrombocytopenia, it was deranged liver function and acute renal failure. This goes into a strong suspicion of tropical fever like leptospira. As we see a number of cases these days, they presented with the complications of renal failure as well as deranged LFTs with decreased platelets, as well as we see WBC. There is no leukopenia in such case from the day one. So this goes into strong suspicion of leptospira. In spite of leptospira IgM was negative, we continued with penicillins as well as doxycycline, and finally after sending PCR, we got it a positive result, and after the clinical images like diffuse alveolar hemorrhage and acute renal failure, we could clearly the patient had improved after the successful management of ECMO and CRRT.
Sir, a question for you, Somnath sir. So, because most commonly you would be facing, these cases on an outpatient basis also. So, do you see any change in the trend of leptospira cases in this monsoon, especially with the unprecedented rains happening at this point of time?
Yeah. Usually, whenever we present with we see with the leptospira, a lot of cases initially come with a anecdotic phase, like just with a fever, with some flu-like symptoms. So when we go into a labs, we find that the dip in platelet count with a normal WBC count or increased WBC count with a mild deranged liver function test, which we see in all kind of dengue infections as well as seasonal flus also. So, but nowadays, what we are seeing is like even it is a dengue or even it is a suspected dengue or looks like a flu-like symptoms with a mild deranged liver function with the transaminitis as well as thrombocytopenia. We are already starting everyone on a doxycycline. We are not going directly into the test of leptospira unless there is acute renal failure as well as deranged liver function test. This test is a bit like it takes 3-4 days for the test to come. Similarly, and it is not very common to do this test. So I think a lot of people are masking after starting doxycycline, and they have been improving. Whether we are not getting into that the patient has a leptospira or not.
And as we see this case, sir, because this came from not an urban setup, this came from a rural. So, do you see any difference in the presentation for a patient who is presenting from an urban setup compared to a rural setup, sir?
Clinical scenario wise, there is no difference between the urban and rural. Like it usually, as you discussed earlier, leptospira such cases starts from the stagnant water where a urine sample gets contaminated with the water, and gets touched with your exposed mucosal areas or any cut areas. So the clinical symptoms in the urban and rural are completely same, but the only problem in the rural is diagnostic evaluation will be bit delayed, or there's a lot of confusion. They just think that it is a dengue or some other flu-like, and they just start on a symptomatic management where they miss starting doxycycline or penicillins, and the patient lands into icteric phase or a severe Wills disease kind of case where they go to the urban center. When they come to the urban center, we could see that the patient is already having acute renal failure where the patient requires hemodialysis, similarly ventilatory supports or finally to ECMO, which we have seen in this kind of cases. So, but where in urban population, we could have availability of tests. Similarly, these cases have been seen very commonly. So, or we would have started empirical doxycycline, seeing the scenarios where we could miss the complications in such cases.
Sir Pradeep, sir, as we move forward, so when do you suspect diffuse alveolar hemorrhage, sir? Because if you look at the X-ray initially here, it was absolutely normal, and the moment we intubated, we started to see hemorrhagic secretions. So what makes you to suspect whether this could be a possible, diffuse alveolar hemorrhage case?
So at the initial presentation of this patient, you would have probably not suspected DAH. DAH is generally suspected, when you have diffuse bilateral infiltrates, anemia, and hypoxemic respiratory failure. This can have associated hemoptysis or bloody secretions, but in up to 30 to 40% of such patients, they may not have hemoptysis. But considering that the initial X-ray was normal, and even you saw that the lower cuts where you could probably see till the hilum, you did not see in the initial abdominal CT, you did not see gross, alveolar opacities on the CT. So probably this patient developed DAH during our hospital stay rather than presenting to us with DAH.
Okay, sir. So, I mean, when you see such case, sir, so what are the common causes, particularly in our country, which comes to your mind, and what should be, be evaluating for in such scenarios, sir?
So the most common cause of DAH is alveolar capillaritis. More than 80% are caused by that. And of course, the most common cause of that is ANCA-associated vasculitis. The second most common cause of capillaritis is Goodpasture's or anti-GBM disease. Of course, in our country, we always need to keep on the back of our mind regarding infections like Leptospira, Mycoplasma, dengue, sometimes rarely malaria. Even bacterial infections such as staph and strep are known to cause a DAH. And in case you have an immunocompromised patient, you would probably even consider fungal causes like, rarely Aspergillus and CMV as a cause of, DAH in such patients. But overall, majority of our patients with DAH usually have associated vasculitis. So as we have seen that even we have for this patient evaluated by ANA, ANCA, and we were considering sending anti-GBM antibody in this patient also. So I think this is the most important diagnostic workup to evaluate for the cause of the DAH. Of course, apparently the routine workup for the infectious diseases is being done. And in such cases, in case you are suspecting DAH and you want a quick diagnosis, of course, doing a bronchoalveolar lavage will help in such cases for two reasons. Once, it will help you diagnose DAH, and second, it will help you rule out acute infections in case we decide to treat with high dose immunosuppressants.
Sir. A question common to both of you, sir. So, how commonly do we see diffuse alveolar hemorrhage in tropical infections, sir? I think some of the things which you have discussed, like dengue, but how commonly do we come across such scenarios in day-to-day practice?
Yeah, definitely in dengue, we have seen such diffuse alveolar hemorrhage cases, but it is one of the complication which we have been seen like at least in 1 in thousands, 1 in 10,000 dengue cases. Similarly, in Leptospira also, Leptospira manifests with lot of renal failures as well as similarly with the deranged liver function test and thrombocytopenia. But going into diffuse alveolar hemorrhage as well as ARDS is like a 1 in 100, 1 in 500 kind of cases. So all the tropical fevers which we see diffuse alveolar hemorrhage, but it is one of the rarest manifestations, and it only seen in like a immune phase, kind of going into the patient going into the immune phase.
So as sir rightly mentioned, sir, it's not at all a common manifestation. And I think if you go through literature about lepto, even the patients with say, severe leptospirosis, even in such case patients, we only see in about 3 to 5% of the cases that DAH actually develops.
Somnath sir, question to you, sir, because of probably you would have been seeing patients from very long time. So did really the clinical presentation change over time, sir, with the way things were manifesting? Because when we were taught in our medical schools, it was more like lepto presents with the thrombocytopenia. So any differential diagnosis for any tropical fever, we should consider lepto. Then we started to understand, we do see with hepatic involvement, then renal. So, did this clinical presentation change over time? Because I think last time when we did a session also, we presented three different varieties of leptospirosis which presented with ARDS, sir. So this is the extreme of that cases. So is it changing over time, sir?
Yeah, definitely. When we see a classical case of leptospira, it is always a biphasic kind of disease. Like initially, it has been like 4 to 7 days. We presents with a kind of constitutional symptoms of flu-like symptoms with high-grade fever, body pains, headache, and some kind of conjunctivitis, vomiting, nausea, these kind of symptoms. But after that, it goes into immune phase where the patient may have aseptic meningitis with a deranged liver function, mild jaundice, as well as renal impairment, a few uveitis. But definitely there are always like a few patients land into Will's disease also, like having some hemorrhagic manifestation with renal failure and jaundice. But definitely other than this, there will be some atypical presentations or also like the patient directly comes with a diffuse alveolar hemorrhage or ARDS to us without going into this phases biphasic phase, like first initial phase of few days. Like this patient, when we see this history of fever is just for 3 to 4 days before going into the immune phase. So similarly, if you present with the myocarditis, if you present with the cardiomyopathy, if you present with the arrhythmias just after the fever without landing into the renal failure or hepatitis kind of phase. If you present with a kind of altered sensorium, when we examine, when we go into, they present with the meningoencephalitis. When we go with the workup, then we found that it is a leptospira positive. And if you have some gastrointestinal symptoms also like acute pancreatitis, if you present with a organomegaly like hepatosplenomegaly as well as some abdominal, acute abdomen kind of symptoms, there may be some other manifestations like if you have a severe rhabdomyolysis like myalgias, myositis. Similarly, when we see the CPK levels, which is the increasing trend, then they land into renal failure. These are the different atypical presentations which we have seen in leptospira, but the classical symptoms were always present when which were masking with this atypical presentation.
So how commonly do we, can, like, because patients may present with an ARDS and DAH, sir. So what points will tilt you towards, making you think that probably this may be a pulmonary involvement of a leptospirosis in the form of an ARDS or DAH, sir?
Yeah, when the patient lands into the DH as well as ARDS, we need to see the history clearly, whether the patient had an onset of fever with any contact with any kind of rodents as well as any like animals. Similarly, when we go into the clinical or diagnostic reports, investigations wise, the patient initially would have been having deranged liver function test with a kind of renal failure. Then I think that may be the phase where they may land into going into the DH, which we see in these leptospira cases these days. So any like we have seen 2 to 3 cases landing into the ARDS recently in last 1 year, out of which all the cases has been gone from the deranged liver function test with mild jaundice as well as similarly renal failure, then landing into the ARDS. So when we see investigations thrombocytopenia with LFTs and RFTs deranged and with ARDS, then we need to have a strong clinical suspicion differential diagnosis of leptospira to be added.
Okay, sir. Coming to management of these kind of patients, sir, a question common to both of you. Role of steroids in this patient, because one of the audience has asked any role of steroids in this patient.
The role of steroids is always controversial in any kind of infections like this. When the patient is in sepsis, I don't think so. Steroids like high dose of steroids will help you. But when the patient lands into ARDS, having some complications like this patient, then definitely some stress dose of steroids will be beneficial, and it will be helpful for decreasing the duration of ventilatory support. Similarly, reversing the ARDS. Similarly, helping in early improvement. But I don't think so. High dose of steroids will be beneficial in these kind of cases.
So definitely, sir, as sir said, role in treating the infection, definitely the answer will be a no. The role of treating DAH with steroids is controversial. The mechanism of DAH in leptospira is multifactorial, sir. It is immune mediated, it is toxin mediated, it is also because of thrombocytopenia. So there are in some case reports, they have used high dose steroids, but overall the meta-analysis of such case reports has not shown any significant benefits of steroids in managing DAH with leptospirosis.
Yes, sir. Like rightly what you have said, probably in this patient, like what Somnath sir has said, is not an ideal candidate for use of steroids in this patient, because there are other potential sources of infection which we had, urinary tract, then lung. So that would have been a disaster for us. But there are many other case reports when I was going through the literature which showed that they have tried, patient clinically improved, and they have recommended. But the strong meta-analysis, I mean, strong evidence for steroids is still lacking, but it has been tried on and off on a case-to-case basis as such. When I talk about steroids, obviously the other two modalities of therapies also come into picture. The role of IVIG and plasmapheresis, sir. A question common to both of you, sir.
Yeah, regarding IV agent plasma versus for this kind of cases, definitely in dengue we have tried and we have been successful in a lot of cases. But in leptospira, personally in my cases I never tried, so I'm clueless.
No.
Yeah, that's there is no evidence that any of these two modalities will help in any infection related DAH as such. The role of Plex only comes in anti-GBM DAH. Otherwise, there is no direct role of Plex in any other cause of DAH.
Yes, sir. As rightly said, because the pathophysiological mechanism is what makes it different actually. And even if you look at the other causes of DH, even for an ANCA vasculitis, as a refractory measure, we can use plasma exchange with a doubtful benefit rather than straightforward plasmapheresis. So only even for a routine immune-mediated ANCA vasculitis, the role of plasma exchange is questionable. So I think with a infectious setting, probably even as Somnath sir said, we never had experience of using plasma exchange in these subset of patients as such. So coming to the question on ECMO. So because there was a lot of debate, because when I went back to the literature, there are two case reports, one from the Thailand, one from the USA, where they have used ECMO. And the case from the United States of America, they had catastrophic bleeding where they ended up using, they activated massive transfusion protocol, and they had multi-organ failure. Patient had to be airlifted to a different hospital. So they had multiple challenges. So here, ECMO as a bridging therapy in this category of patients, because it was not easy for us as a team to take the decision. So, what were your thoughts or what were your insights into, ECMO for these patients?
For this case, especially for this case, we had tried multiple options. Initially, patient was HFNC not maintaining. We had ventilated the patient. We saw the CT images, which were like very bad. It was almost a whitewash. Then we tried prone ventilation for 1 or 2 days. The patient was maintaining, but there was a lot of edema, facial edema. Similarly, when we tried to supine, the patient was not comfortable, her oxygen levels are falling. There was no option other than counseling the patient for VV ECMO in spite of thrombocytopenia as well as bleeding manifestations. So finally we are successful in managing the case. She's like comfortable right now, like within a short duration of 7 days of we could stop the ECMO supports. So I think definitely I have a very little knowledge about ECMO, but after seeing this case, like definitely in these cases, early interventions rather than trying on ventilatory support for more days, proning on for more days, rather than we could, even after having a lot of challenges, we could try ECMO, and definitely it was one of the successful case.
Pratib sir, any comments on this, sir?
So I think the challenge here again for ECMO was regarding the bleeding part. So initially, we have initiated ECMO without anticoagulation. I think that is what is probably, helped us get through this part. We should probably go back and see whether in the US case report also, whether, they have started them on anticoagulation or they withheld anticoagulation. I think the tricky part was, having successful cannulation with such slow platelet count and bleeding manifestations, and then maintaining the circuit and clotting, prevent it not clotting up even without anticoagulation. I think the second part is because it was an infectious cause, and because I think the therapy of lepto was started much earlier. I think because of that, we were able to, decannulate her and wean her off the ECMO very quickly. If she would have probably required a prolonged ECMO, then it would have been an even more complicated thing, because then we would have had to give some amount of anticoagulation, or else the circuit would have definitely clotted pretty soon. So because of it being an infectious cause, and the appropriate antibiotics being started, during the initial part of the presentation, and which helped in quick recovery and quick weaning and quick decannulation.
As you rightly said, sir, because this was one of the most difficult decision for us as a team to take, with the platelet count sitting at around 80,000. Because at this platelet count, probably we would not, we have never dared to do any ECMO cannulation, and that too, without need for anticoagulation, because the problem is with the large cannulas where there is a problem of, circuit clogging and all. And once we had these reports of, vasculitis, everything being negative, and the lepto coming positive, we are very sure that it is probably that leptospira related capillarities, which is a ooze which is happening. And with lot of deliberation and discussion with multiple experts across India, where everyone had a very limited experience regarding managing these kind of cases. So with all this support, we could successfully initiate and maintain with a low dose anticoagulant. And this also happens to be one of our shortest ECMO which we have ever placed. And I would also touch upon the last question, which is the teamwork in this patient, probably where everybody tried to chip in and do their best to make this patient better. So any comments on those this teamwork, sir?
Yeah, definitely. A lot of teamwork has been involved in this case. I could see there was a coordinated multidisciplinary approach, like pulmonologist, nephrologist, and a physician with a microbiologist, as well as from the critical care team, which was a strong support where you could have been like early antibiotic therapy was started with penicillins as well as doxycycline, and we have been like seeing the other sources, like whether there's the autoimmune involvement in this case. Similarly, we are doing for sepsis workup, urosepsis workup. We intervened. We took, even after a lot of challenge of oxygen support, not able to maintain. We could have a DJ stenting with anesthesia. We could electively intubate this patient. Otherwise, I think with such high lactates as well as severe acidosis, we couldn't have been able to survive the patient. And all the things has been done in time, because of which the patient could survive in a shorter duration. As you said, ECMO was only for 7 days, which was the shortest in our cases, especially. So teamwork, multidisciplinary coordinated team approach is more important in surviving these kind of cases where you require early diagnostics, similarly early starter treatment, and similarly approach from all the different sites, like use of ventilator supports, use of ECMO supports. Similarly, in such challenging cases, if, unless and until there is a proper ICU care with such a good team, it will not be possible.
Definitely, sir. Any such a critical patient will require multidisciplinary work, to successfully treat them and get them out. I think apart from the teamwork, I think, the area where, we accepted the ICU team and the primary physician Somnath sir, we accepted that we will take the difficult route, even though the ECMO might be difficult, even though ECMO might, put the patient's life in danger. It was the only path for us, and being a tertiary care center, we have to take the difficult decisions and do the difficult things. And I think because of that, the patient has had a successful outcome today.
And on this forum, I must thank multiple people here. One starting from Somnath sir, and this patient happens to be one of his classmates' relative. So to discuss this patient and take the timely, quick decision at that point of time. And from the beginning, we had support from the anesthesia team, urology team, nephro team. Then when we had to cannulate this patient, in fact, if you look at the picture, it was midnight where we have cannulated this patient. And we had support from the vascular team in managing this cannulating this patient. Then we had support from pulmonology team who could come in and do the bronchoscopy at the midnight for this patient. So the perfusionist, everyone has to pitch in, and I think that's what makes the team a successful one, and because of which we are right now able to sit and talk about a success story. I think I must thank each and everyone who has contributed for helping this patient. uh, I think with this, I have no more questions to both the panelists. So I think I have answered most of the questions from the audience also. So why did you suspect, leptospira very strongly? I think probably one of the reason being the clinical spectrum or the pattern of presentation. I think the clinical intrusion of both, the medicine, Dr. Somnath sir, and the ICU team in suspecting that yes, even though the dengue IgM came weakly positive or the lepto IgM came negative, still that is not ruled out as such, and we continued with our treatment of leptospirosis. I think that is what is a clinical suspicion which made us still towards that. And I think the other question was any role of steroids in this patient. I think we had an extensive discussion. Other question being, why such high leukocytosis? Probably there are a couple of reasons. One is she was having a secondary infection, because if you look at her urine picture, again she had some amount of urinary tract infection. Along with that, we have used steroids, and lastly she developed some secondary infection in the form of a VAP. All these three contributed to her high leukocytosis. I
There was
think.
some amount of leukemia reaction also in this case.
Yes, sir. Yes, sir.
When the patient was recovering at that time, we saw serial CRP levels as well as we did a procal also. Those are all improving, and procal was almost near normal, and the WBC counts were around 35,000. So it looks like more of leukemia reaction when she is improving from the sepsis as well as from this leptospirosis.
And in fact, we had, as I mentioned earlier, also we had done a session before the leptospira varied presentation. I think Somnath sir was panelist during that time also,
Yeah.
where we had three different cases where they presented in a different presentation. And one of the patients we had used steroids also for leptospira ARDS actually. Again, that was hydrocortisone only, where all the three patients had mild hemoptysis, respiratory failure, and if I'm not wrong, one patient went on to ventilator, one patient went to ventilation along with the prone ventilation also, and all three of them recovered. So to conclude, what I would say is, respiratory involvement, although described rare in the literature, because I think what sir pointed out was, most of these patients do take initial treatment in the rural setup from a local practitioner, and it goes undiagnosed, and by the time they present to us, most of the time they will be in multi-organ failure with renal and liver and lung involvement too. Lung involvement, not a classical presentation, but it does present, and when it does present, it does scare us. So any other final comments from the expert panelists, sir?
I think DAH with leptospira has a mortality of nearly 70%, sir. But you have managed 3 cases with DAH and ARDS, all 3 were successful outcomes. So I think that's a great result.
I think probably we are fortunate with the way things are happening, sir, and hope we continue to do the same with all the support, sir. If there are no further comments, sir, then we'll close the session, sir. Thank you, Somnath sir, for joining us, and
Yes,
thank
sir.
you, Pratib sir, for joining us.
Thank you, sir.
Thank you, sir.
And we continue to bring further sessions on an interesting topic every week. Please do join us. Thank you.
Thank you, sir.